way of remembering it, and
Sure, sir.
looking
We will
forward
try
to
to
its
do that
existence.
only, but it totally depends on the availability of speakers also, sir. But we will try to keep it definitely on first Tuesday of every month, as you suggested.
Yeah, I think now Dr. Neha is the, I can see her login.
Yeah. So over to you, sir.
Please.
I think we can good to go and start with Dr. Neha's session.
Yeah, we'll start at 5. So it's 1 minute
Right,
more.
sir.
Dr. Neha, have you downloaded the software and your slides will be okay?
I hope so. Yes, I've not downloaded the software, but I have logged in through that link.
Okay. So we start at 5.
I I'm just looking at it and stopped sharing your screen. So this is sharing my screen right now.
Yeah, press that. It hasn't
I
come
did.
up to.
Yeah, that's what I'm thinking.
Yeah.
It hasn't. Yeah, I don't think it has come here. So is it like visible now?
Yeah, now we can see.
You can see, right? Okay, fine.
So do you want to do a self introduction or you want me to introduce you?
So if you can have, you can just say a little word about me, or else whatever you say.
All right, let's start. So, good afternoon, good evening, and good morning wherever you are to all of you uh, who have logged in today for infectious disease ki Paathshala. This is the first Paathshala that Jolly Healthcare, which is dedicated for enabling doctors worldwide, and they focus on rare and neglected drugs and diseases. Today, we have two very important topics and very eminent speakers. The first topic is syphilis, the great imitator, and on that, Dr. Neha Gupta would speak about syphilis and old disease in this new world. Dr. Gupta is a senior infectious disease physician. After obtaining MD in medicine, she went on to be in the first batch who have done infectious disease in India from Hinduja Hospital.
Okay.
Thereafter, she's been trained in CMC Vellore and in USA, and she's worked in Fortis Memorial Research Institute as well as Medanta. Now, she's founder of Swasth Infectious Disease Clinic in Gurgaon. Dr. Neha Gupta, please.
Thank you so much, sir, for a very nice introduction. And first of all, I'm thankful to Jolly Healthcare for providing this opportunity and starting this initiative of infectious diseases. Today, we are going to discuss on syphilis, which is one of the oldest known infectious diseases. And we are going to just see how the spectrum has been in this new world as well. So before I start, I would just like to acknowledge my mentors, Dr. Rajiv Soman and Dr. Kamla Rodriguez, who have really guided so many students like us and trained so many fellows like us and shaped the lives of so many people. Um, well, the association between syphilis and the world of literature is very fascinating, and in fact, the name of this disease has originated from a poem called Syphilis, which was written by an Italian physician. And the poem tells the story of a shepherd named Syphilis who blamed and insulted the sun god for the drought. which led to the demise of his flocks, and in turn received this defect punishment of this horrific disease. So the humanity has been suffering from this disease for more than 500 years, and in the initial first 100 years after the first reported outbreak of syphilis, which was in 1495, the disease was much more severe, as the symptoms were described were much more severe as compared to what we see in the modern syphilis manifestations. And over the next few centuries, in fact, the description of the signs and symptoms of syphilis in the literature reflect a very seemingly attenuated form of this disease. And there have been so many historical plays where syphilis has also been mentioned, and there have been so many documentaries as well where syphilis has been portrayed as a disease which is
Please bear with us. Dr. Neha will be online. Would somebody please check with Dr. Neha? Dev, you're on screen. Dr. Neha has dropped out. Is anybody inquiring about what is happening?
Hello.
Yes,
Yeah,
come.
I just got a message from Dr. Neha that there is a power cut at her place. So there is a she is trying to be another alternative options. Meanwhile, if it is feasible, can we go ahead with the second session first, or power cut will
Okay,
may take some time, sir. So as per your suggestion, we can go ahead.
if Dr. Animesh is ready, then Dr. Animesh, can you take over? Let me introduce Dr. Animesh when he gets ready. Dr. Animesh Ray is Associate Professor at the All India Institute of Medical Sciences, New Delhi. After doing MD Medicine, he had also obtained DNB and MNAMS, and he's a consultant in both medicine and critical care. He is also MRCP from UK, and he has fellowship from ISDA, ICP, uh, ISMED, and NCCP, and he would speak today about amphotericin B myths and facts. And Dr. Animesh Ray, you could load your slides and take the session over. Yes, your slides are there.
Right. Okay. Are my slides visible?
Yes, and
Yes,
we can
yes.
hear you. Go ahead.
Okay. So I'm new to large. So the issue is I cannot see any of the no, I cannot see any of the other participants with this. I'm not sure. How do I know that the other people are still there? Mm,
No, we'll give you a feedback in case anything goes wrong. At the
okay.
moment, again, your slides have gone,
Yeah.
and now we can see only the
So
opening
when I
screen.
so when I'm talking, my video is not working, right? My video is not there. Only my audio is there. Is that so? Okay. Anyway. Um, just let me know when my slides are visible again. So are my
Yes,
slides?
now we can see.
Okay. So can you see me as well? Can you see me as well?
Yes, yes.
Yes,
Okay. Okay. Because I cannot see. Okay. So then probably it's a one-way thing. Okay. So it doesn't matter. So thank you very much for having me here. So I'm starting earlier than was planned, but that's how life is. You have to make arrangements for the unexpected. So thank you, Dr. Ratan, for the kind introduction. I'm sorry about those degrees. So actually, I'm basically an internist and I'm a pulmonologist. I'm with special interest in pulmonary infections. So I'm working at AIMS in New Delhi for the last 7 years, and I'm mainly concentrating on the various aspects of pulmonary infection, more specifically pulmonary fungal infection. Right. So this is the topic I'm going to talk about over the next 25-30 minutes. So this talk is titled as Amphotericin B in the Management of Invasive Fungal Infection, Myths and Facts. So what I'll try to do is I'll try to talk a little bit about the molecule of amphotericin B with the clinical relevance of it, and I'm going to use a case or two in order to build on the different perspectives of amphotericin B, as well as to answer the possible questions related to choice of molecule, the dosing, the adverse effects, and so on. Right. So I'm told that the August audience here they are already dealing with the different nuances of infectious disease. So please bear with me, and if at times it appears to be a little too simplistic, but I will try to do justice to the topic in general. So amphotericin B, I think we all know that it's a broad spectrum antifungal. The group which it belongs to is called polyene, and it has been considered to be a gold standard, and it is in fact one of the most widely used antifungal for a very long time. So let us cut to the chase. Let us start off with a case and see how the different aspects of amphotericin B we need to decide on that and how we get to decide on that. So this is about a 65-year-old female patient, a known case of dilated cardiomyopathy, a breast cancer survivor who has received chemotherapy recently, say 1 week, and she's presenting with a history of fever for the last 3 days. On examination, we do not get any localizing signs or symptoms, and she is vitally stable. The physician, the treating physician, he does a complete blood count and see that the neutrophil count is very low. So the patient was promptly started on injection meropenem, a broad spectrum antibiotic. However, 48 hours later, there were no relief of symptoms, and so further investigations were planned. So a radiograph was done, which showed bilateral air space opacities, as well as a CT thorax was done, which showed the classical halo sign, as we call it. So a GGOs surrounding a consolidation halo sign, which in the right background might indicate a possible pulmonary fungal infection, more specifically aspergillus. So, in fact, a serum galactomannan also returned positive. And so now the treating physician thought about whether or not to add antifungal. If yes, what type of antifungal. So we are not talking about febrile neutropenia, but just as an approach to a patient of febrile neutropenia. Whenever a patient of febrile neutropenia comes, we stratify the patient high risk or low risk. So in this case, the patient was high risk because her chance of having neutropenia was more than 7 days. Next, what we see is whether the patient is clinically stable or unstable. If the patient is clinically unstable, then we kind of literally throw everything at him or her. So we do all the investigations, start off with broad spectrum antibiotics, as well as we have a low threshold for empiric antifungal therapy. If the patient is clinically stable, then we have some time. Then we probe into the history and we see whether the patient is receiving some prophylaxis. And depending on what kind of prophylaxis the patient is receiving, we can choose one or more of the antifungal therapy. Our patient was actually not on any kind of antifungal prophylaxis. So at this juncture, our treating physician thought of deciding between azoles and amphotericin B. He wanted a broad spectrum coverage, so he thought that he's going to choose amphotericin B. So the options which he had was deoxycholate, a lipid complex, amphotericin B lipid complex, or a liposomal amphotericin B. Right. So how does he go about this? So this brings us to my first fact versus myth question. Uh, liposomal amphotericin B, is it always better than the others? So is this a myth or a fact? Because our treating physician thought the liposomal amphotericin B is costlier, so this must be better than the others. So his, or in fact our choice of antifungal depends on a number of factors. So first is side effect, cost, and efficacy. So we are going to talk about all of this in the subsequent slides. And the answer to my first myth, fact versus myth question, I would try to give it by the end of my seminar. So a little bit about amphotericin B. I understand that history is not really our forte. So for most of our doctors, but I think it's good to know that amphotericin B has been around for a long, long time, much before most of us were born. So 1954, it was discovered. 1965, so more than 50 years back, it was approved. And subsequently, around 3 decades back, the different forms. So amphotericin B lipid complex and the colloidal dispersion, which is not being used nowadays that much, and the liposomal amphotericin B, they were approved by FDA. And gradually other improvements happen. But I think these are the important landmarks, which says that amphotericin B has been around for a long time, and it still is our best bet in a number of clinical situations. Briefly about the pharmacology of amphotericin B, which is clinically relevant. So amphotericin B has a hydrophilic and a hydrophobic chain, which kind of binds to sterol. Now, how does it cause its antifungal activity? So sterol is a component of ergosterol. So amphotericin B, what it does is binds to the ergosterol, leads to formation of leaks in the hydrophilic pores. So electrolytes go into the fungal cell, and there is osmotic disturbance, and the fungi dies. So this is simple. But talking about sterol, there is another sterol in the host membrane, that is the human membrane, which is the cholesterol. So amphotericin B also acts on the cholesterol, and by the same mechanism, it can cause mammalian cell death, that is human cell death, and the different side effects. But lucky for us, the affinity of amphotericin B for ergosterol is several times, say 10 times more than that of cholesterol. So as a result of which, there is more benefit, there is more fungal death as compared to adverse effect, say as compared to mammalian cell death. So this is, again a good to know fact about amphotericin B. So the initially what came around was the amphotericin B deoxycholate, which looked like a micelle. You can see it looks like a micelle from our biochemistry classes. We can remember what the micelle structure was. Now there were some modifications made to liposome to the amphotericin B, so that its toxicity decreases. So how was it done? It was done mainly by increasing the size, so that there is lesser sequestration to say the kidney. It was also done by increasing the surface charges so that less of it leaves the vascular space and makes it to the different host organs. So here we can see the liposomal amphotericin B, which is spherical, and the ABLC, or the amphotericin B lipid complex, which is again the largest of the three lipid formulations, and which actually looks like a ribbon. So the other is the amphotericin B lipid emulsion. So I don't have a photograph for that, but what lipid emulsion actually means is that the amphotericin B is kind of dispersed in a lipid solution. It is emulsified in a lipid solution. Previously, it was more or less an in-house preparation. Nowadays, different pharmaceutical companies, they have also come up with standardized amphotericin B lipid emulsion. So these are kind of all lipid formulations of amphotericin B. Briefly about the pharmacokinetics, it is not absorbed orally, so it is given mostly intravenously. It is highly protein bound, and we don't know much about how it is eliminated. Only thing which we know that around less than 5% there is urinary and biliary excretion. So this is for the deoxycholate. It is much lesser for the liposomal or the lipid complex molecule. And what is interesting is that hepatic or renal dysfunction does not actually alter its serum concentration. So the crux is that if there is hepatic or renal dysfunction, there may not be any need for modification of the amphotericin B doses as such. So again, it's a long table, but I think this is the pick of the lot. Size, as I said, deoxycholate is the smallest, while that of the others they are larger, and which leads to low plasma concentration, peak plasma concentration of the deoxycholate as compared to the liposomal amphotericin B. Regarding the tissue concentration, I think this is also interesting, and this actually brings me to the second fact versus myth question, which is that the tissue concentration of the different formulations are same. Is it a myth or a fact? So this is a myth. This is not true, as we can see from this particular table. Now, again, this table looks a little daunting, but let me just quickly take you through this table. So here is the deoxycholate lipid complex and the liposomal amphotericin B, and we have got the different tissue structures here: eye, skin, lung. So what is interesting to notice that in the liver, so the color coding, there has been some color coding. Green means that there is very good concentration in that particular organ, more than 5 times the plasma concentration. Orange is somewhere in between. You remember the traffic lights, so orange is somewhere in between. So zero point 0.5 to 5. And red means very less tissue concentration. So if we look at the liver and the spleen, what we can see is that they are all green. So there is very good concentration in the reticuloendothelial system. For kidney, there is some difference. Deoxycholate is green. Lipid complex, whatever data we have got, it is also good. But liposomal, there is the concentration is not much. So one fallout of this particular knowledge is that in say fungal infection of the urinary tract, deoxycholate may be a better option than liposomal amphotericin B. But again, a caveat is higher concentration may not translate into better efficacy, which we are going to see subsequently. So, for example, here the lung, right? We can see that the lipid complex, it is green, and liposomal it is orange, and deoxycholate, the data is, some says it is not that good, to okay type, so red to orange. But then again, the later the trials which I'm going to show you, it would show that in invasive pulmonary aspergillosis, the efficacy, that is the benefit therapeutic benefit of these all these preparations may not differ. So it's good to know, but again we have to know which ones we can use, translate to a clinical practice. As I told you, it's a broad spectrum antifungal. So does it mean that all fungi are susceptible? So you have a suspected fungal infection, you can just shoot amphotericin B and forget. So is it a myth or a fact? So is it obviously a myth? It's not true. There are some organisms which are intrinsically known to be resistant to amphotericin B. So say Candida auris, which is causing a lot of problems in ICUs throughout India. So Candida auris is known to be intrinsically resistant, as also Sporothrix, Fusarium, Cerosporium, and other fungi. So, bottom line is that though broad spectrum, you have to still look for the putative fungal organism and try to tailor your therapy accordingly. In fact, amphotericin B is not only a broad spectrum antifungal; it can be used for protozoal disease as well. So I think we all know this, but it's just to put this information in perspective. It has been used in Kala-Azar, sleeping sickness, say wherever it is prevalent, Africa and other countries, as well as it has anti-amoebic properties as well. So amphotericin B can in fact be used in other diseases like protozoal diseases. I've told you that amphotericin B is predominantly used intravenously. So can it be used via other routes? Yes, it can be. So apart from intravenous, oral, there are some studies where there are phase 3 studies which are going on, which are trying to use amphotericin B orally. But more common is the use, say, in bladder as bladder irrigation, say for candiduria, resistant candiduria, some cases of fungal meningitis, refractory or intraperitoneal, where there is a candida peritonitis not responding to standard therapy. So there are chances of increasing additions to use of intraperitoneal therapy. One other important mode of administration is aerosolized or nebulized amphotericin B, and I'm going to talk about it in a little bit detail because I had the opportunity of working on this particular aspect very recently. Nebulized amphotericin B, in the context of a case, we can argue that just like IV colistin, which is used also used inhalationally, can nebulized amphotericin be used in our case of invasive pulmonary aspergillosis? So you remember our case, 65-year-old female patient having breast cancer, presenting with febrile neutropenia. She was having lung lesions suggestive of an Galactoman positivity. So basically, probable invasive pulmonary aspergillosis. So will this patient benefit with the use of nebulized amphotericin B? So to understand this, so a little bit about nebulized amphotericin B. Nebulized amphotericin B has shown to be effective as prophylaxis for invasive fungal infection in the background of hematological or lung transplant patients. It has also, there's some evidence that it can be used as an adjunctive treatment of refractory invasive fungal infections of lung. So when you're giving, say, amphotericin B, you have added azole, say voriconazole, patient is not showing treatment, not showing response, then you're thinking about adding therapy to that. There, nebulized amphotericin B might be helpful, but it's not standard of therapy. In fact, it is not also standard of therapy in chronic pulmonary aspergillosis. So this is a trial where I've been a part of this trial, where nebulized amphotericin B was pitted against oral itraconazole in patients with simple pulmonary aspergilloma. There, we were able to show that that nebulized amphotericin B was in fact non-inferior to itraconazole, and in some patients it actually produced dramatic benefits with minimal side effects. So bronchospasm was the only side effect which was present, say around 30% of patients, but none of the patients the therapy needed to be discontinued. Again, this is not standard of care, but the point which I'm trying to make is that amphotericin B can also be used via other routes other than intravenous route. So this kind of brings us to the next question. The fact versus myth question is that the doses of the different formulations are they interchangeable? Now, this is a very important question clinically. So, if you are choosing deoxycholate versus vis-a-vis liposomal, will the dose change? So deoxycholate is typically given in the dose of 0.5 to 1 milligram. We can extend up to 1.5 milligram per kg. For lipid complex, it is usually 5 milligram per kg. And for liposomal, it is 3 to 5 milligram per kg. But some diseases like say mucormycosis, so ECMM says that we can increase the dose right up to 10 milligram per kg. Usually, modification in hepatic and renal dysfunction is not required. So the answer to this question is that whenever we are choosing a particular formulation of amphotericin B, we have to be very careful about the dose, maximum dose which we can give, and the dose which we are prescribing for that particular fungal disease. Coming back to our question, our physician actually decided to start the patient on amphotericin B deoxycholate. So the same patient, she was started on amphotericin B deoxycholate, and on the first day she had reaction, infusion reaction. She had fever, chills, and she appeared to be sick. So the next question is that should amphotericin B be discontinued? So talking about the adverse effects of amphotericin B, we have usually three type of common adverse effects. The first is the infusion related. So normally nausea, vomiting, chills or rigor, or fever. It usually starts within 15 minutes to 3 hours. So this time is important because if nausea, vomiting, chill, rigors happen before say 15 minutes, we have to think about the possibility of anaphylaxis and we have to monitor the patient closely. For treating nausea, any symptomatic treatment, prochlorperazine, ondansetron is sufficient. For fever, antipyretic, even NSAIDs may be given. Some patients who are given amphotericin B through the peripheral veins, they usually have phlebitis. So thrombophlebitis, which is very distressing. So in this case, usually using of alternate sites, central line, ensuring that the concentration is as mentioned in the package insert, and kind of prolonging the infusion time is helpful. The next set of adverse effect, which is very important, is the nephrotoxicity. So you have to remember that any formulation, in fact, all formulations, they are toxic to the kidney, but some are more than the other. Usually around 50%. So there's a broad range. 5 to 80% of the patients might show a transient decline in the GFR, and this might be exacerbated by some risk factors, like if the patient is volume depleted, concurrent nephrotoxins. So typically, 1 pint of normal saline is given immediately prior to or divided before and after amphotericin B administration. So how does the AKI happen? So AKI is usually by two mechanisms. There is a renal vasoconstriction, which is usually reversible by volume loading, and other is tubular toxicity. Now, tubular toxicity happens when the amphotericin B molecule makes their way to the renal tubules and comes into direct contact with the tubules. Now, since we know that the liposomal and the lipid complex, their renal their entry into the kidney, the tubules, is restricted because of their larger size, so their tubular toxicity is as such less. So the factors which determine amphotericin B adverse effect is one is obviously the dose, more the toxic effect. Lipid formulations usually have a lesser nephrotoxicity. Concurrent therapy with the nephrotoxins, I talked about that, and obviously the patient has a chronic kidney disease. There is more chance of sustaining a acute kidney injury over and above that. So our patient, again, so the patient was managed with IV Avil. This was restarted, and she took it for a couple of days. Then what she complained next was that she said that she was having frequent micturition of large volumes of urine. So her urine output was measured, and it was more than 4 liters of urine per day. So what is the patient having, and does this require discontinuation of the amphotericin B? So, so this is in fact the not so common adverse effect, but still it is encountered in clinical practice where the patient is having nephrogenic diabetes insipidus due to the resistance to the ADH as a result of amphotericin B. So usually how we manage it is we treat the concomitant hypokalemia. A low sodium, low protein diet leads to less amount of urine output, and these drugs, thiazides, which has got paradoxical action in nephrogenic diabetes insipidus, NSAIDs, or last resort, desmopressin may be tried. So upfront, amphotericin B may not be discontinued, but these measures should be started first. Finally, the third set of the adverse effect is the electrolyte abnormalities, hypokalemia, hypomagnesemia, as well as acidosis. They are very common, and they occur due to increased distal tubular permeability. So something, a similar, our case who is kind of, you must have understood, is prone to adverse effect. She's having one adverse effect or other, though it is exaggerated, but it is not uncommon to see more than one adverse effect in a particular patient. So our patient, she complained of palpitation, and on the third day of treatment, and a lab result revealed a mild, moderate hypokalemia, and the ECG was done, which was kind of alarming. There were some flutter waves here, and the atrial rate was close to 300. So the patient has mild hypokalemia. So does this patient need modification of therapy? Because our physician needs to decide whether this ECG manifestation is related to the amphotericin B administration. Well, the answer to that is, if you remember, this patient was a case of dilated cardiomyopathy. She was on diuretics. She was also on digoxin. So amphotericin B can cause hypokalemia. Hypokalemia, we know, can lead to exacerbation of digoxin toxicity. So this patient probably is having a manifestation of digoxin toxicity. So what we need to do is correct hypokalemia, do serum digoxin level, hold digoxin, and then take a decision about continuing amphotericin B. Other adverse effects not that common: bone marrow suppression, leukopenia, anemia, and the dreaded but rare complication of anaphylaxis. They can also be seen. Talking about anaphylaxis, um, it can happen with any of the formulation, and one formulation once used, normally the formulation should not once we are using it and leading to anaphylaxis, it should not be reused again. But sometimes, as I'm going to show you in the subsequent case, there may not be any alternative. So what can we do in that? So in these cases where there is anaphylaxis, we don't have any other option. Can amphotericin be still be reused, or is it a myth or a fact? So this is about desensitization to liposomal amphotericin B. This was about a COVID patient who came to us with COVID-associated mucormycosis. Outside hospital, multiple episodes of anaphylaxis to multiple formulations. In a hospital also we tried, and there was anaphylaxis. Patient could not afford isobuconazole, and we thought we were in a fix. So we reviewed literature and we saw that there was a concept called desensitization. Patient given sequential higher concentrations of amphotericin B so that his body gets acclimatized and there is no mast cell release and histamine release uh, post amphotericin B administration. So in fact, this patient had a favorable outcome. We could start liposomal amphotericin B after desensitizing him. So desensitization might be an option, but again, this is for specialized centers, and we have to be careful before using it for all patients. So if you have an option, use the other option. If you don't have, you think about desensitization. Coming back to our patient, a patient by the end of the first week, she showed there was an increase in the creatinine level. So it has, which was normal previously, it has creeped up to more than 3.5. So what should we do? Should we stop the deoxycolate or we can continue it? We have seen that renal modification is not required. So here again, the usual practice is that if the creatinine for a patient who is otherwise having a normal kidney function, the creatinine rises above 2.5. Normally, we go on to a less nephrotoxic alternative. So if the patient is having deoxycolate, we move on to liposomal. If we are not able to do that, what we do is we try to decrease the dose for a few days, and then we try to track the creatinine level. If the creatinine comes down, which it usually does, then we can think about gradually restarting amphotericin B at a higher dose. So stopping of therapy is not indicated, but probably switching to liposomal may be indicated in this case. So this is a patient monitoring chart, a simplistic patient monitoring chart that we use. So cumulative dose, electrolytes, urea creatinine. We also monitor the CBC weekly and LFT if clinically indicated, and also the pre-medication given. We keep a tab on this. We also do the daily KFT up to 2 weeks, and then depending on what the KFT is, we can choose to decrease the frequency. And we also document infusion related reactions. So we can see that the adverse effect of liposomal amphotericin B is lesser than that of deoxycolate. Right? But is it always innocent? Well, that is not the case. So here is a case of a patient with HIV-related histoplasmosis where liposomal amphotericin B was given and it was completed within 50 minutes. And within 5 minutes, the patient had chest pain, dyspnea, abdominal pain, no hypotension, no other features of anaphylaxis as such. So the infusion was stopped and the patient was started on IV diphenhydramine, to which the patient responded. So this is a rare case, but sometimes you might encounter it. This is called a CARPA or a complement activation related pseudoallergy. Pseudoallergy because it is not immune mediated. There is a type 1 hypersensitivity reaction and there is release of histamine due to degranulation from the mast cells. Okay. Coming to the cost, so this is again intuitive. Deoxycolate is the cheapest, lipid complex is more expensive, and liposomal is usually more expensive. Now, this is from a, a particular company, but depending on the brand, the cost may be higher. But usually, this is the norm. Deoxycholate is the cheapest. Liposomal is the most expensive. Coming on to the efficacy of deoxycholate by the versus the lipid formulations. So, are lipid formulations more efficacious? So, we are talking about this during the concentration in the tissue concentration in the different organs. So, the different studies which have been done, right? So, they have shown either a no difference or a equivalent clinical outcomes between lipid complex liposomal or liposomal and deoxy, except for one study done in the early part of this millennium, where histoplasmosis patient HIV liposomal amphotericin B was associated with higher rates of clinical success. So the bottom line, what I'm trying to say is that side effect profile, amphotericin, liposomal, and the lipid complex, they definitely have an upper hand. But efficacy wise, there may not be much of the difference between the two. In fact, in some conditions, as I said, like deoxycholate, fungal infection of the UTI, deoxycholate may be better than the lipid preparations. While in other scenarios, histoplasmosis, etc., liposomal amphotericin B might have an edge over the others. So the choice of antifungals, you are the first fact versus myth question, as we saw. So if you can just sum it up, cost, we know deoxycholate is the cheapest. Side effect, again, it weighs in favor of liposomal, which has got usually the best side effect profile. And efficacy wise, we still do not have a conclusive study which says that one form of amphotericin B is better than the others. So this kind of brings me to the last slide. So I would like to summarize whatever I said, my all the 13 fact and myth questions by saying that amphotericin B, it is a reliable drug, a broad spectrum antifungal, but the type of drug, the type of formulation which we choose would depend on the different factors: efficacy, cost, side effects. Side effects, there are three types: commonly infusion related nephrotoxicity and electrolyte disturbances. And it's very important to remember that these formulations, they're not interchangeable. So what you should normally do is, if you choose a particular formulation, you should go to the package insert, the literature, and you should see how it is supposed to be administered, whether say sonication is required, whether NS is supposed to be used or dextrose is supposed to be used, and what is the concentration, final concentration of the drug, and what is the dose of the drug before subjecting the patient to a potentially toxic therapy. Right. So this is all I've got. Um, I'll be very happy for any questions.
Thank you, Dr. Ray. There are two questions. One is by Tarun, who wants to know that is there any Indian data to indicate to manage amphotericin B toxicity by saline overloading, as you explained? Is there some Indian data available that you can share with him?
So there is obviously some Indian data. So from the tropical school of tropical medicine, I can there was a study on liposomal amphotericin B. I think the brand was Fungizome, and they had talked about the their experience in managing the adverse effects, the toxicity. There they had shown that for Fungizome, loading with a particular amount of normal saline is actually helpful. There have been some other studies. I mean, though the numbers, they are not much, but I think the bottom line remains the same. The bottom line is that volume loading is important. Now, how much of volume loading, it would depend on the patient's clinical condition, whether the patient has heart failure, etc. Normally, we start with 500 ml, but if we see that the patient is progressively getting edematous, patient has heart failure is getting exacerbated, then we might choose for a lesser volume of the fluid.
And there's another question by Sudeep asking about which formulation should be used in pediatric patients.
So okay, so most of these formulations, they can be used above 1 year. But again, I would not commit, because I'm not a pediatrician, so I need to check that. But as far as my knowledge goes, and what I remember, that most of these drugs, they can be used safely in patients, beyond, even pediatric patients beyond 1 year.
Okay, right. Thank you very much. You were a saver for the group today by stepping in when Neha was blacked out because of the electricity failure. And now that electricity is back and Neha is with us, we will revert back to Dr. Neha. And Dr. Neha, you can share your slides
Sure.
and restart your presentation. Thank you, Dr. Ray.
Yeah. So now I can.
Yeah, go ahead.
Yeah, yeah, sure. So thank you so much. It was a wonderful lecture by Dr. Animesh on the basics, and of course, he touched upon many new points as well regarding. One of them was, I think, uh, desensitization of amphotericin. This is something which we have not done it in our private practice as of now, and it was something which was very nice to learn from you. So we'll move on to syphilis, and I think I have around 10-15 minutes left, so I'll try to complete it during this time. So, despite all our desperate efforts, syphilis has been on a rise over the last few decades, especially. This is the data from the CDC, which shows that there has been a gradual increase in the number of cases, and this is predominantly attributed to multiple factors, including an increase in the use of pre exposure prophylaxis, effective antiretroviral therapy, as well as the concept of U is equal to U, which actually leads to use of condoms sex among MSM and people living with HIV. So it has been a very long and complicated battle with syphilis, and as Dr. Ashok Ratan also mentioned earlier, that this is a great imitator because of the various clinical presentations it exhibits. So I'll start off with this particular case. This is a 54-year-old lady who is having hypertension and diabetes, and she has lichen planus of the vulva for the last 12 years, and she was on treatment for the topical steroids. Then she presented in Kolkata. This is a very this is one of the first cases which I had seen during my fellowship there in 2010. So she had presented with right ankle pain, which was not much of swelling, and she also did not have neuropathy, no fever at that time. The ankle pain persisted, which was persisting despite the NSAIDs. And the next day, she developed maculopapular rash on the palms and the soles. And also, she developed a low grade fever, which was persisting on and off. There were no other ulcers and no other manifestations as such. Now, for these complaints of fever, arthritis, as well as rashes on the palms and soles, she went from Kolkata to Hyderabad, and they considered differential diagnosis of SLE, connective tissue disorder, reactive arthritis, and she was extensively worked up as well, which shows that she had a normal WBC count. The ESR was very much elevated, and she also had mild LFT alterations. There was an increase in the serum globulin levels. The other investigations were normal. The X-ray of the knee joint uh, showed that there was some problem. There was a reduction in the medial tibiofemoral space, and also she underwent a extensive vasculitis workup, which was negative. The urine was showing that there was some pustules, and at this point they thought that probably it's reactive arthritis because the urine culture was showing Klebsiella pneumoniae, and she was received the treatment with augmentin for 5 days. But the rashes as well as the pain progressed further, and it was more diffuse, and it just mild itchy all over the face as well as the trunk, and she started spiking very high fever along with facial puffiness, which was probably manifestation of the kidney involvement. So the repeat workup was done, which again showed that there was an increase in the ESR, and she was also investigated for the various atypical infections as well. Now, with these complaints, she presented to us in Hinduja in Mumbai, and on examination, the vitals were normal. There was no lymphadenopathy, there were no thickened nerves. There were rashes like this, which we can see on the face, trunk, palms, and the soles. So she had these diffuse maculopapular rashes all over the body on the trunk. These were typically present on the palms and the soles, and the credit will go to Dr. Soman for this case as well as for the pictures. So these are these co-emitting lesions as well. And again, we can see that these are the lesions which are present on the soles. So with this, there was several differential diagnoses of fever with maculopapular rash, which we considered, including the vasculitic eruptions, connective tissue disorders, infections including viral infections, atypical measles, other bacterial infections including rickettsiosis, bacterial endocarditis, atypical infections, and of course, could it be related to drugs, other not so common etiologies like the sweet syndrome, and other etiologies like the sarcoidosis or the lichen planus. So she was further investigated, and we also involved um, our dermatologist at that point, who examined, and this was a typical Buschke Ollendorff sign, which he said that is characteristic of this particular entity. So with the back head of the pin, he actually pressed at these rashes, and there was deep dermal tenderness which could be elicited. And these rashes which were seen on the hands and the feet, they were basically maculopapular followed by desquamation. So this is also very characteristic of what we are discussing today, that is syphilis. So the skin biopsy which was done, which also revealed that there is almost nodular perivascular collection of the lymphocytes. As we can see here, these are all nodular collection of the lymphocytes which are seen, perivascular, and there was plasma cells which are seen in the lower dermis surrounding the adnexal structure. So, as clinicians, we must always interact with our various specialities, and I happened to interact with the histopathologist on this, and she mentioned that what is very important is not the lymphocytes, but it is the plasma cells. So, plasma cells is very characteristically seen in case of syphilis. So, a lot of times we may have a biopsy which can be done either from the lymph node or from any of the skin lesion, and it's important to see whether it has plasma cells predominantly, because that is going to give us a clue towards the probable syphilis as the etiology. Now, the VTRL which was performed was positive as well, and it was 1 is to 32. The TPHA was positive. She was negative from the HIV workup as well as the other investigations like the pap smear, everything was negative, and she was not really ready at this point for the CSF. So now with this, we discuss whether what is true in this particular patient. So if VDRL is positive, TPHA is not needed. If TPHA is positive, VDRL is not needed. If VDRL is negative, then TPHA is not needed. Or if TPHA is negative, then VDRL is not needed. So we'll discuss each one of this one by one, and the the test which we have for the diagnosis of syphilis, they are basically classified as non-treponemal test and the treponemal test. The non-treponemal test includes the RPR as well as the VDRL. The treponemal test includes the TPHA, FTA, ABS, and the EIA. And the non-treponemal tests are the ones which detects the antibodies to the cardiolipin and are not specific to the treponemal infection. So there can be certain false positive results, like 1 to 3% of the cases, and these are usually associated with multiple conditions including pregnancy, HIV, TB, IBTO, rickettsial infections, as well as autoimmune disorders. However, they can also be false negative in case of primary syphilis, latent syphilis, and tertiary syphilis. Usually, secondary syphilis, these tests are likely to be um, positive in close to 100% of the times. But sometimes they say that if there is prozone phenomena, then the non-treponemal test can also be falsely negative in case of secondary syphilis. And most importantly, these tests are likely to be non-reactive once we have given treatment to the patient, so they are useful for the treatment monitoring. Now coming to the treponema test, so these are much more specific for the treponema pallidum. However, they can be positive in the other treponema infections like the yaws and the pinta. However, these are really not seen in our country as such. The disadvantage is that they cannot distinguish between a treated and an untreated infection. TPHA is like a monitor which remains positive for life. So, and this is the sensitivity of the various serodiagnostic tests if in case of an untreated syphilis. So, we have VDRL and RPR with a close to 100% sensitivity in case of secondary syphilis, whereas the sensitivity is definitely less in case of primary, latent, and the tertiary syphilis. In fact, tertiary syphilis it is only 70% sensitive, whereas the other tests, including the FDA ABS as well as the TPHA, they have a much higher sensitivity in case of the tertiary syphilis, latent as well as the primary syphilis, and that is why, in fact, there is a reverse algorithm which is being practiced and recommended by the CDC now in order to prevent missing out the other forms and stages of syphilis. So, coming to our discussion, so if VDRL is positive, TPHA is still needed because to rule out false positive VDRL. If TPHA is positive, VDRL is needed for the treatment monitoring. VDRL is negative, TPHA is definitely needed because VDRL is negative on in close to 70% of the cases of neurosyphilis, which is particularly in patients with HIV. This becomes very important. So the correct answer is that if TPHA is negative, VDRL is not needed, and TPHA perhaps is the better initial sensitivity screening test rather than VDRL per se. Now, coming back to our case, now in this particular patient, the issue was how do we treat her? Definitely, she has extensive lesions all over her body. She has maculopapular rash, which is on the palms and the soles, and it kind of fits into secondary syphilis. But it's very important to rule out neurosyphilis in this lady because in syphilis, it is, although traditionally we say that neurosyphilis is a late manifestation, but CNS infection represents a continuum from the early invasion within the first few weeks of the asymptomatic involvement to the late neurological manifestation. It means that the CNS infection can happen even in the early stages of the illness, and in fact 40% of the patients with primary syphilis or secondary syphilis, if they have been found to have the CNS involvement. So ideally, we should do a CSF VDRL or a CSF FTA ABS. But if that's not available, then we must treat her like a tertiary syphilis. Now, why do we need to treat it or stage it? This is because the treatment is different for all forms of syphilis. If we look at, this is a table which briefly summarizes the drug of choice for the syphilis. So in all forms, it is definitely penicillin, which is the drug of choice. But what happens is the it's for penicillin G is the drug of choice for the primary, secondary, and the early latent syphilis, whereas for the late latent it is again benzathine penicillin. But for the neurosyphilis, it is the crystalline penicillin which is the drug of choice. So the form of penicillin obviously changes, and we will come to this that why penicillin or crystalline penicillin is the drug of choice in the subsequent slides. So, for primary syphilis, secondary or a early latent syphilis, it's a single dose of the benzathine penicillin which is effective, and the concentration of this drug remains in the body for close to 3 to 4 weeks in a quantity which can effectively kill the bacteria. Whereas for the late latent syphilis, the dose has to be given weekly for 3 weeks, and for the neurosyphilis, it's crystalline penicillin, which has to be given in more frequently. We need a drug which is much more frequent at a higher concentration for for killing the bacteria, for the killing this treponemal bacteria. In case there is allergies, then the alternative strategies would be tetracyclines, which can be used for the primary, secondary, and the early latent. The duration of therapy is 2 weeks, whereas for the late latent as well as the non-CNS tertiary syphilis, the duration of therapy with the tetracyclines is 4 weeks. And alternative strategy has also been recommended with the uh, ceftriaxone as well. Now, in this lady, because there was a long duration of illness with multiple organ involvement and a very high VDRL type, with a VDRL titer of more than 1 is to 32, she was treated with the crystalline penicillin, as it was very likely it could have been a asymptomatic neurosyphilis. Now, what should we do in the follow up? It's important to follow up the titers, and a four-fold decline in the titer is important to assess the efficacy of the treatment. And ideally, the titer should become non reactive in 6 months. If it does not, then there is a consideration for the retreatment. I'll move on to this quick short case of a 40-year-old gentleman who had diabetes. And in July and August 2021, he started having some deafness in his right ear. And slowly later on, he was simultaneously, he started having some redness as well as blurring of the vision. And he was found to, this was a fundus examination which was done, which showed that he has got necrotizing retinitis and pan uveitis. The VDRL titer was very high, the TPHA was positive, and he was also diagnosed with HIV-1 with a CD4 count of 630. And so this is a patient who has HIV-1 with ocular syphilis. Again, the recommendation for the treatment of ocular syphilis is to give crystalline penicillin at a dose of 18 to 24 million units per day, which has to be given for a period of 14 days, and simultaneously steroids have to be given. So why penicillin for Treponema pallidum? So as such, Treponema pallidum is very difficult to culture, so we do not have any sensitivity data per se. But penicillin has been shown to be effective, and we need a drug which achieves a good concentration and is able to kill the virus. We need a sidal therapy for the Treponema pallidum for two reasons. First of all, the inflammation which is produced, the meningeal inflammation, is a low grade inflammation, and also the Treponema pallidum has a very slow rate of replication in the mammalian tissues. So, because of this, a sidal drug is needed, and the minimum serum concentration of 0.02 microns per ml for a period of at least 7 to 10 days is needed for the sidal effect. So, this is in vogue with the concepts of the current time above MIC as per the PKBT. So, I would just like to summarize this that for as per this famous quote from Eagles and colleagues, who said that Treponema pallidum is one of the most sensitive as well as one of the most resistant of all the bacteria to the action of penicillin, and most sensitive in terms of the smallest concentration which is needed, which is bactericidal, and most resistant in terms of the time it must be exposed to that concentration to get killed. So it's very important to choose a drug which can reach a concentration above the MIC for killing this particular bacteria, which is replicating at a very slow rate. And that is why crystalline penicillin is considered as the drug of choice for the neurosyphilis or ocular or even the otitic syphilis. Thank you so much. And in fact, this is one of the famous paintings by a very renowned German artist of this woodcut of a syphilitic man who is covered with all the syphilitic lesions. And this was earlier known as the French disease. So, if there are any questions, we can take them as well. Uh-huh.
No, there were no questions which was asked in this. Of course, as you know, that syphilis has been on the rise in the recent past, though
Absolutely.
WHO has indicated that by 2030 we should decrease syphilis by 90%. At this moment, in 2020, it was reported that 7 million new cases of syphilis occurred, and so they hope that by 2030 we would have decreased the the new infections by 90%. Thank you very much, Dr. Neha, for a brilliant talk. And you've covered and explained why aqueous crystalline penicillin is required. But of course, the standard treatment is
benzothine
benzathine
penicillin.
penicillin, because penicillin prolongs the life of penicillin, and as she said, is time over MIC that is more critical for bactericidal activity, and that must be always more than 40% of the duration. One dose is enough. That is what we were taught, that one dose is enough. But CDC writes that if it is latent tuberculosis and late
This,
syphilis, or latent or late
this,
syphilis, then you might have to give 3 doses
three
at
doses.
weekly interval.
Correct.
With this, we come to the end, and I uh, thank the organizers for organizing this. And they tell me that similar Paathshalas will be held every month from now onwards. I thank you all, and we see you next time again. Thank you.
Thank you so much. Thank you.
Thank you, sir.
So
Hello.
my was um, my
Yes.
video was off.
No, no, that's
No,
okay.
ma'am, everything was no crystal clear. We could see all the slides very well, and
Correct.
Yeah,
I would
No,
like
no
but
to.
my video
problem.
was off.
No,
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 ma'am, your video
we
was
could
also
see
on.
you.
Acha, okay, okay. Because I just when I now just closed the slides, I was seeing my video as off, so that is why I was asking.
No,
Okay.
no, now only might be just
Maybe.
the software is doing some tricks
You
in
know,
between.
and yeah,
Okay.
the other thing which I was thinking, the flyer which was shared, it should ideally have, I think, a registration link, and also it should be shared on the WhatsApp.
Ma'am,
Because
we
Yeah.
shared it on WhatsApp only, and it has a
no, no, no,
registration
no.
link.
No, but see, even my, like, for example, my coordinator was just trying and she was not able to log on to it. I
I
don't
know,
know
ma'am.
what was the reason, and it demanded for again a code. So that code, not everybody will be having it. And plus, if suppose it is not the flyer, but it's a written content on the WhatsApp, it is much easier to operate, enjoy. This is my
Surely,
personal
ma'am, we have
experience.
noted it down, and as we are going to have these sessions every month, so we will definitely improve it, and we'll make sure that all the
Yeah,
participants
yeah,
don't face
yeah,
such
yeah.
kinds of no hurdles. And I will also, yeah, the scan code definitely will be a very feasible option. No, so we'll put a scan, no, that QR code over there, so anybody can scan and just join it from their
Yeah,
Okay.
mobile phone or
that
anything.
seems to be a
It
better
would be a
option.
more, yeah. So,
Okay, good.
Ashok sir, Dr. Ashok Ratan sir, with your permission, I would like to just take 2 minutes, no, to give a no, permission from my MD to no, say a thank you note on behalf of Jolly Healthcare to all the speakers and even to Dr. Ashok Ratan, who has not really helped us a lot being a moderator. So, Avish sir, are you there? Avish sir, can you hear us? Okay. So might be host has to unmute him. So Dev sir, can you please unmute Avi sir?
Everybody's unmuted. No,
Avi sir, can
is
you
he
hear
there?
us? Okay, maybe some network issue. So on behalf of our MD sir, I would like to say a very big thanks to Dr. Animesh Ray, Dr. Neha ma'am, and even definitely Dr. Ashok sir has really given a good overall things to the this webinar. And sir, thank you so much for also suggesting that we should have it on now every Tuesday to it can be remembered by everyone it becomes like an habit to everyone. So definitely we will try to do that on every first Tuesday of the month with availability of the speakers. And we also would like to ask you again, if any day you can come up, and help us again with any of our session. That will be a very, we will be blessed to have you again on the session, sir. So that's all from your side. And anything you would like to say on closing notes, sir? Over to you.
No, thanks everybody, and we hope to see you again. Thank you.
Thank you.
Logging off.
हाँ